Welcome to a special edition of Informed Dissent for Monday, May 18th of 2026. What you are about to hear was recorded inside of a continuing medical education session at the 2026 American Psychiatric Association's annual meeting in San Francisco, which took place on Saturday, May 16th of 2026. The presenters you will hear are Dr. Jack Turban and Dr. Dan Karasic, two of the most prominent and influential voices shaping the clinical standard of care for gender dysphoria in the United States. We have received this audio and we have verified its authenticity. We are releasing it in full with no edits to content. The only alterations were made to audio quality. We have done what we could to make it as clear and audible as possible. What you hear is what was said. We want to be direct about why we are doing this. CME sessions are not private conversations. They are credentialing events. The content that is delivered in these rooms travels directly into clinical practice, into the offices where patients sit, into the decisions being made about children and adolescents, and into the testimony being offered in courtrooms and legislative hearings. The public, patients, parents, and the policymakers being asked to legislate in this space have a legitimate interest in knowing what the American Psychiatry Association is teaching its practitioners behind closed doors. Dr. Jack Turban and Dr. Karasic are not private citizens. They are the architects of a clinical framework that has shaped policy, influenced courts, and affected the lives of tens of thousands of patients. What they teach in a CME session is their professional position. It belongs in the public record. We believe in transparency. We believe patients deserve to know what is being said in their name. We believe parents deserve to know what the clinicians treating their children are being taught. And we believe that anyone with the power to make or sustain policy in this area has an obligation to hear it directly. So we are not going to summarize it. We are not going to interpret it for you. We are going to let you hear it. What follows is the full audio from session 1193 at the 2026 American Psychiatric Association's annual meeting. A continuing medical education session titled Transgender Care, Update on Evidence-Based and Clinical Practice of Primary Care, Child and Adolescent Psychiatry, and Adult Psychiatry.
Financial relationships, pharmaceutical relationships, but I have been an expert witness in numerous cases related to access to care for transgender people, including with the ACLU, medical legal, and CLR, and others.
We have breaking news. The Department of Health and Human Services says gender-affirming care poses a risk to children's health and well-being. HHS Secretary Kennedy just introduced what the department calls actions to protect children from harmful medical interventions.
The American Medical Association, the American Academy of Pediatrics, held the line that chemical and surgical sex rejecting procedures could be good for children who suffer from gender dysphoria. They betrayed the estimated 300,000 American youth ages 13 to 17, conditioned to believe that sex can be changed. They betrayed their Hippocratic oath to do no harm. So-called gender-affirming care has inflicted lasting physical and psychological damage on vulnerable young people. This is not medicine, it is malpractice. We're done with junk science driven by ideological pursuits, not the well-being of children.
Last month, the department finalized a report on gender-affirming care for youth, claiming it found, quote, medical dangers posed to children. The report alleges that gender-affirming care, including puberty blockers, cross-sex hormones, and gender-affirming surgeries, cause significant long-term damage. Now, the House has passed a bill that would criminalize gender transition treatments such as surgery and hormones for minors. Let's bring in University of California, San Francisco professor emeritus of psychiatry, Dr. Dan Karasic, for more on this. Dr. Karasic, thank you for coming on. The Academy of Pediatrics hasn't responded yet to this announcement, but in reaction to a May report on this topic, they said, and I'm quoting here, that the report misrepresents the current medical consensus and fails to reflect the realities of pediatric care. So what's your reaction to the Health Secretary's announcement today?
So the HHS report, frankly, would make George Orwell blush. It is a compendium of disinformation that dismisses decades of experience working with trans youth, all of the research supporting those efforts, and replaces that with authors who are all part of organizations that are dedicated to ending care for transgender people. In doing so, they're asking parents to disregard their experience with their own adolescent children, the work that those youth have done with therapists, with their doctors. These are people who may be engaged in care, may already be on hormones, may have already transitioned, and the Trump administration is putting these families in the middle of the culture war and ripping away their health care with nothing to replace it. And I think it's unconscionable and it do great harm.
The Secretary of County says these gender transition treatments are neither safe nor effective for children, and that there's an overwhelming body of evidence that these procedures hurt rather than help kids. What's your response to that?
That's a lie. There is enormous amount of evidence. The HHS document itself mischaracterizes and dismisses that evidence and substitutes it with innuendo, with references to op-eds, references to lawsuits, to references to podcasts of people opposed to transgender care. It's really a disgrace. And then, this was constructed clearly as a basis of fulfilling a campaign promise to end care to trans youth. And so this whole document is a rationalization for it. But it has no basis in reality, and I could go on for days with all the lies really that are there.
And Doctor, I'm out of time, but quickly, the House has now voted to criminalize gender transition treatments for minors, like surgery or hormones. That still would have to pass the Senate and so on, but what would it mean for doctors and patients if that were to become law?
Well, doctors would stop providing that care and would still have their careers and be able to work taking care of cisgender youth, but the trans youth and their families would be the ones hurt. There are already families that had to move from states that had banned care to states that still allow it, and now every family I know has a contingency plan of moving abroad or going abroad to get care or finding ways to get care still in the United States. And it's been tremendously stressful. The Turban Project had a study showing a dramatic increase in suicide attempts in the states that have banned gender-affirming care. And I'm very worried for the well-being of trans youth who are having their care ripped away.
All right, Dr. Dan Karasic, we appreciate your time today. Thank you.
Thank you.
So, fortunately, a federal judge did block RFK Jr.'s declaration, which would take away all government funding, Medicaid and Medicare funding from providers and medical centers that provided gender-affirming care even to one patient. However, there continues to be a process that CMS has already taken public comment on to try to enact the same ban in a different administrative way. So I'm just going to talk a little bit about some of the misinformation that has been a justification for the HHS document or put out there. Starting with a fake tweet about something I said 3 years ago at a UCSF training, where this was tweeted in many different forms, but basically they took an audio tape where one of my colleagues, Diane Aronsack, was responding from the audience to another person in the audience who had asked about severely autistic nonverbal children. And in any event, Diane Aronsack gave an anecdote about a nonverbal autistic child with precocious puberty who was on puberty blockers, but it didn't even, require a evaluation at that point, a gender evaluation. But this was put out as in social media and repeatedly, and I ended up testifying about it in Florida in 2023. I had emailed one of the people who ended up being one of the authors of the HHS 49-page document that the government is now saying gender-affirming care should be based on, and said your own tweet that had an audio tape of Diane Aronsack that was attributing things to me was false, and yet it still appears in the HHS document along with a whole compendium of stuff that's made up. This place in the HHS document has a reference to John Strang, who's an American psychologist who did a consensus document that Diane Aronsack and I, along with other American providers of care to people with autism spectrum disorder who also had gender dysphoria, along with the Dutch. And so it was actually a consensus between the Americans and the Dutch. And yet it's portrayed over here as if the leading specialists in the US are somehow divergent when they're actually citing a consensus document. And for evidence of that, they use a podcast with an audio tape of this UCSF training that's been misinterpreted. And so if you go through the HHS document very similarly, point by point, it's just creating false assertions. And it wouldn't be such a big issue, except for now the government is using this both to this HHS document, both as the basis to deny care to youth, but also to adults. So another place is where it says that I had a conflict of interest in defining treatment for adolescents as medically necessary when I had nothing to do with the adolescent chapter, and my involvement with medical necessity that they cite had to do with placement of this medical necessity statement, which had been in WPATH to put out in relation to Standard Care 6 and Standard Care 7. Standard Care 7, the surgery chapter is transgender surgery is medically necessary. So it was not as if I was having a conflict of interest in making it medically necessary, or its medical necessity is based on you know, on somebody advocating for it. It's just a way of dismissing the standards of care and every path that's being politically motivated. Another place for the HHS document dismisses our current working knowledge of transgender care is using systematic reviews and grade scores. You see this now just in newspaper commentaries everywhere about this low certainty evidence supporting gender-affirming care. They do this at the same time that they're endorsing treatments that have little or no evidence, including psychotherapy to address gender dysphoria. When there's no evidence that you can resolve gender dysphoria with psychotherapy, and there are no systematic reviews demonstrating that. And the way we make clinical decisions is by comparing evidence of different interventions. So just to run down how we practice medicine generally. In one large study of systematic reviews, only 5.6% of all medical interventions and 0% of all endocrine interventions had a high grade score. Most medical interventions have low or very low grade scores. In another systematic review of anesthesiology, critical care medicine, emergency medicine, only 10% have high grade scores, and yet no state has banned the practice of anesthesiology, critical care medicine, or emergency medicine. For complex interventions, so a complex intervention is one where there are multiple steps to enact the intervention and then multiple steps to measure a result. So if you were just looking at do puberty blockers stop puberty, there's high quality evidence that puberty blockers stop puberty. But if you're looking at does transition lead to a long-term happy life, there are many steps involved in that. And in complex interventions and systematic reviews, no high grade scores for any complex intervention was found. And in terms of national guidelines for care, only a minority of national guidelines for care are based on strong and moderate grade scores. You make these recommendations based on comparison with alternatives, and there's no evidence to support the alternatives that they bring up. Last year at APA, there were some presenters who did a talk on why systematic reviews mean people should not provide gender-affirming medical care to youth and instead should provide psychotherapy. But the authors of the systematic reviews that they used in that presentation have rejected that interpretation of their work. So the Gordon Guyot and the group at McMaster University on evidence-based medicine that have done the North American systematic reviews, or many of them on gender-affirming care for youth, they said it is profoundly misguided to cast healthcare based on low certainty evidence as bad care or care driven by ideology, and low certainty evidence as bad science. Many of the interventions we offer are based on low certainty evidence, and enlightened individuals often legitimately and wisely choose such interventions. Thus, forbidding delivery of gender-affirming care and limiting medical management options on the basis of low certainty evidence is a clear violation of the principles of evidence-based shared decision-making and is unconscionable. The appropriate use of our work is ensuring that patients receive needed care and helping transgender and gender-diverse patients and their clinicians in decision-making. So the HHS document, after dismissing gender-affirming medical care, which in the Taylor review for, in the Taylor systematic review for the CAS review from the UK, found moderate quality evidence that hormones provide benefit. They dismiss that and then say that psychotherapy is the more effective intervention, and say that it's supported by high quality evidence. But if you actually look at HHS's own systematic review of psychotherapy for depression for adolescents, all of the interventions have either low quality evidence or insufficient evidence. So even HHS's own review shows a lower certainty for psychotherapy for depression than hormones for gender dysphoria. But that's even missing the point that there's no evidence for psychotherapy for gender dysphoria. But clearly they have this double standard, may mislead in the HHS document that it's high quality evidence when it's not. There is moderate quality evidence for CBT for anxiety. They also have misinformation on trends in transgender care in Europe. And again, this would not be a large point except for it's just repeatedly mentioned such that then it's been picked up in common media, and it's based on mischaracterization of care in Europe. So just to give you an example, there are references to Sweden and Scandinavia going another way from the US, but if you actually look at the Swedish guidelines that the HHS document actually cites, it's very similar to WCAT Standards of Care Adolescent chapter, which was, the co-lead was the leader of the psychiatrist leader of the Dutch group. A difference is that it talks about starting puberty blockers at Tanner stage 3, so it is a more conservative approach, but it's far closer to WCAT's standards than to what HHS is suggesting, which is a total ban. And there's also in public media a lot of references to Finland and this Finnish study that showed that people in Finland, median age, I believe 18 and a half, who got gender-affirming medical care had higher mental health utilization than those that did not get that care. But it ignores that the same senior author's paper in another study broke down the need for psychiatric treatment by before and after hormones were started. And it showed that even though the percent that needed psychiatric treatment stayed about the same, that the number that were needed treatment for depression went down from 54% to 15%, for anxiety, 48% to 15%, and for suicidality and self-harm, from 35% to 4%. So it clearly showed when that was broken down, a great improvement when people were started on hormones. But when you zoom out and you just look at people's need for psychiatric treatment, you don't necessarily see that effect. And yet the study with the negative report from Finland is you just repeatedly use justification for that. So I'm going to talk a bit about restriction of care for adults, which actually has been going on for several years, but it's accelerated, and in particular, just 2 months ago, the Fourth Circuit reversed its finding that that gender-affirming care for both for minors and adults was medically necessary and it could be medically necessary, and applied Scrimeti to adult care, So the idea that you're not discriminating against trans people if you're just discriminating against their diagnosis. And so Scribetti and Medina was a case about Medicaid and Planned Parenthood, or state funding of Planned Parenthood. There's been an acceleration in states of attempts to ban gender-affirming care for adults. In Idaho, it's up to 14 years in prison if you're a doctor and you prescribe hormones to a trans adult who has Medicaid or in a public facility. And that's adults. And other states are restricting care for adults, and meanwhile, the government is restricting rights for trans people in numerous other kind of facets of life. So education, housing, disability claims, passports, the federal government, and birth certificates and driver's licenses for the state. Kansas nullified trans people's driver's licenses overnight. The federal government's, the White House's U.S. counterterrorism strategy for 2026 says, in addition to cartels and Islamist terror groups, our national counterterrorism activities will prioritize the rapid identification and neutralization of violent secular political groups whose ideology is anti-American, radically pro-transgender, and anarchist. There are government efforts to ban the discussion of gender-affirming care. In Florida, there's a lawsuit using the racketeering and consumer fraud ordinances in the state of Florida with a seeking to disband WPATH, the Endocrine Society, and the American Academy of Pediatrics, and ban the distribution of WPATH Standards of Care 8, and have a civil penalty for talking about any benefit that people can get from gender-affirming care. The Federal Trade Commission has been doing an investigation in preparation for a similar lawsuit, though their subpoenas from groups involved in transgender medicine, those three groups have been blocked by federal judges. Just in the past week at NYU Langone, there was a criminal subpoena from the Department of Justice seeking the names of all healthcare providers who had provided gender-affirming care in New York since 2020, at NYU since 2020, and the charts of every minor patient, every patient 18 and under who received gender-affirming care. Notably, in addition, they have subpoenaed all communications with WPATH or any of its members regarding gender-affirming care, including, but not limited to, communication regarding the safety and efficacy of gender-affirming care, and any reference to Standards of Care 8. So I don't know if there are any NYU Langone members in the audience today, but you may have to report your attendance. Also recently, the federal prisons have been forcibly detransitioning trans people who are incarcerated. This was a declaration from the expert representing the government in lawsuits regarding this. And this was someone who spoke at APA last year about why we should follow systematic reviews. And what he wrote in his opinion was, hormone therapy is unproven and experimental treatment for gender dysphoria that generally should not be available to those in custody. Psychotherapy is the preferred treatment approach. And then he said, the affirmation model carries significant risks because humans have immense powers to deceive themselves, and patients may be susceptible to clinicians' suggestions of affirmative treatment. And so then he says, referencing psychodynamic therapy and CBT, that those therapies focus largely on identifying self-deception. And so he is suggesting for people with gender dysphoria that a major target of treatment is helping patients identify how they deceive themselves. So there's no systematic reviews on helping patients identify how they're deceiving themselves and thus resolving gender dysphoria. So after all of this, doing legal bans because something has low certainty evidence on a systematic review, they are trying to enforce on those that can enforce it on, in this case incarcerated people, an intervention that has absolutely no evidence of benefit, and even from one of our speakers today, evidence of harm from conversion therapy. And sadly, conversion therapy is the only constitutionally protected treatment for transgender people in the US today, according to the court, after Childs versus Salazar, and after the Fourth Circuit said that gender-affirming care for adults is not constitutionally protected. So, how has this affected our, in this case, adult patients? Minority stress is associated with depression, suicidality, suicide attempts. Trevor Project has had some studies on increased suicidality with care bans and in those who have not been able to get care as a result. My patients are experiencing, including my adult patients as well as adolescents, increased anxiety, hopelessness, anger. Some have been really working on things like mindfulness, changing focus to things that they're in their control, like hobbies that take them away from looking at the news. So there's, whether it's avoidance or active cognitive coping, people are coping in those ways, but a lot of people are doing active behavioral coping, planning for worsening conditions. I've had several patients who've moved abroad, and fortunately have relationships with providers in other countries who can provide care. Although disturbingly, McGill in Quebec just stopped providing gender-affirming care to American students attending McGill out of fear that the Trump administration can somehow punish a university in another country. And there has been a suggestion of the administration of that if Americans go to other countries for care, that those providers could be banned from entering the United States. And so there is maybe some, reason for fear, but it is something that even internationally, there's the reach of the government. And I have a lot of patients, so I've had patients who, in between visits, I get a call from the patient's mother, can I call in a prescription to a pharmacy in Canada? And, I say, well, no. But I have patients who are disappearing to other countries and even not telling me about it until they're already in the other country for fear of what could happen. And I have patients who are hoarding medications, taking half doses of antidepressants, partial doses of hormones, building up a stockpile either for a bunker or if I have patients who are planning moves to countries that don't carry certain proprietary and expensive psych medicines that I have them on. And so I've had patients have symptoms come back, and it turns out it's because they're splitting a capsule of medication so that they can build up a supply. So, you know, this is a population that already has a higher rate of mental health conditions. It's a vulnerable population. And yet, the minority stress is really, I think, intensifying some of those symptoms. So, so let's see how we're doing. Okay, so well, I'm going to just scroll through just a couple more things. I just want to point out, while I've got the podium, that surgical regret is rare in gender-affirming care. It's still important, and it's something that we need to investigate, and we need to be conscientious with each of our patients. But unfortunately, it's being used by the government to prevent even adults who have transitioned a long time ago from living their lives. In the incarcerated setting, there's incarcerated trans women who have had vaginoplasties, been on hormones for years and years and years, been receiving those hormones in prison, and in response to a Trump administration order, their hormones were abruptly stopped, and they were moved from minimum security women's work camps to higher security men's prisons, where then they've had to be under 24-hour observation because of suicidality that was not there before they were moved. And so, you know, just what's being, this justification of this HHS document to do things that clearly are not therapeutic for people is something that I think needs more attention. You know, the argument is being made that gender-affirming care for adults is experimental, and yet, actually before that, Baflin and Jung have a systematic review from 1961 to 1991, and then building on that, Cornell University did a review of studies from 1991 to 2017, and then Johns Hopkins, commissioned by Transgender Care, did a systematic review in 2021. There are decades and decades of experience to tell us that that conversion therapy, that psychotherapies of all sorts do not resolve gender dysphoria and are not a replacement. And the government should not be abruptly stopping trans people's hormones and saying we can just give them psychotherapy to point out how they're deceiving themselves. And so I think actually I'm going to stop there and hand it over to Jack.
Good morning. I'm Jack Turban. I'm a child and adolescent psychiatrist, and I'm faculty at UCSF, where I direct the Gender Psychiatry program. That's our dual program that provides clinical care to trans youth, and also researches the determinants of mental health for those kids. with a focus on questions relevant to public policy and law. These are my disclosures. And anytime we're talking about any treatments for gender dysphoria, we'll be talking about the use of FDA-approved medications, but they're not FDA-approved medications. And I organized the talk going through stages of development. So first I'll talk about prepubertal kids and how their treatment has evolved over the past 2 decades or so. Then I'll talk about early adolescence and when you might think about pubertal suppression. And then last, talk about later adolescence when we sometimes think about gender-affirming hormones like estrogen and testosterone. I have too many slides, so I'm going to try and talk fast, but if it's too fast, please pause me. Little terminology and background. So 4 important terms to note for this talk. Raise your hand if you already know what all of these are. I'll skip it. Important to know: gender identity, your psychological sense of your gender. Sex are different biological domains, right? It could be external genitalia, chromosomes, etc. And then those are different from gender expression, which is the way you present to the world in a gendered way. So I'm wearing kind of a suit, that would be a masculine gender expression. If I were wearing a dress, that would be a feminine gender expression. I guess for the sake of time too. So why do we think about trans youth so much in psychiatry? And the reason is that there are very high rates of psychiatric morbidity. So very high rates of mood disorders. It's usually major depressive disorder, as common as 64% of young people, depending on the study. Anxiety disorders are also very common. I'd say we most frequently see generalized anxiety disorder and social anxiety disorder, as many as half of kids. And sadly, suicidality is where we see this huge disparity, so as many as 30% of kids, again, depending on the study. The greatest predictors of those adverse mental health outcomes are often projection based on gender identity, projection from parents, projection from peers, bullying, and sadly those rates are also very high, as high as 80% depending on where you're looking. The YRBSS data says the bullying rates are closer to about a third than past year. So this is a graph of different studies looking at suicidality. So on the x-axis is the mean age of people in a given study. On the y-axis is the percentage of people in that study who reported a suicide attempt. The gray line is the general population in the US. That black line represents trans and gender diverse youth. And you can see there's a suicidality disparity pretty much across the life course, but it does seem to intensify in kind of adolescence and early adulthood when we see more experiences of stigma. The minority stress model that Dr. Karasic talked about a little bit is the predominant model for understanding why we see these big mental health disparities for LGBT people broadly. So it was first described in lesbian women, later popularized to describe mental health disparities in gay men, cisgender gay men, and later Hendricks and Testa adapted it to trans people to the gender minority stress model, which is what I have here. It first talks about these distal stress factors. I think they're pretty intuitive. I think of them as external stress factors. So things from the outside world that may worsen your mental health, that are stigma related. So if you were discriminated against, rejected, victimized, you can understand how that would drive anxiety and depression. The slightly less intuitive part are these proximal stress factors. I think of them as internal stress factors, or things that live in your own mind as a result of exposure to those external factors. So things like internalized transphobia. My kids will often hear constantly that being trans is a mental illness, or trans people are dangerous, or trans people are sexual assailants. Right? They know these things aren't true about themselves, but hearing it constantly, you start to get kind of like those cognitive distortions and automatic negative thoughts related to internalized transphobia. Negative expectations is really similar to what we see in trauma-related conditions. So you can imagine if you grew up in Alabama, where you were constantly bullied and physically harassed for being trans, then maybe you moved to San Francisco and live in Castro, where it's somewhat less likely that you'll have those same experiences. You're likely to over-index how likely it is that you're going to experience it. So you might go into Castro Coffee that has a big trans flag, but still feel that fear that something bad is going to happen. And the last one is concealment. So feeling like you need to hide who you are, going in the closet. That can drive shame, which leads to anxiety and depression. The good news is that there are some resilience factors studied that buffer against these negative distal and proximal factors. Important ones are community connectedness. So we're often trying to refer kids to community groups where they can meet other kids like them, share their experiences. Pride is another big one. I have a big poster in my office, should put a picture, of just like badass trans people in all different walks of life. So doctors, lawyers, entertainers, etc. And what should be on this slide is family support also. So a lot of our work is working with kids and their parents to make sure they're really hearing each other so that the parents can understand the kids' experiences, and also a lot of work to make sure the kids can try and understand the parents' concerns. As Dr. Karasic alluded to, what we're seeing a lot more of are these structural factors that you can map onto the minority stress framework. So things like anti-trans laws, executive actions, all of these things in both public policy and law can impact different parts of the minority stress framework. We're starting to see more sophisticated econometric studies in this area that use causal inference methods that can actually infer that certain types of laws are causing either improvement or worsening of mental health at the population level. This was a study in Nature Human Behavior by the Turban project team where they did a composite of different types of anti-trans laws, but found that those laws increased past year suicide attempts among trans and non-binary young people by up to 72%. And that's a lot of different types of laws. So bans on sports participation for trans girls. All of the dark orange states are states that have banned trans girls from competing in women's sports. The other states are states that still allow them. We've seen bans on gender-affirming medical care in about half of states. As Dr. Karasic alluded to, the Supreme Court recently ruled that conversion therapy bans, one of the laws that we know are actually protective for LGBT youth mental health, are subject to strict scrutiny. I'm going to spare you the legal details, but just know that the Supreme Court did not strike down Colorado's conversion therapy ban, but rather they sent it back to the 10th Circuit to evaluate it under something called strict scrutiny, which is very hard for a law to survive. So it's likely that it will be struck down and impact conversion therapy bans in other states. But a lot of states, including California and Colorado, have introduced new laws that just target conversion therapy in a different way to try and still prevent it. And we can talk about those details at the end if people are interested. Okay, let's talk about prepubertal kids, starting with the quiz. So what percentage of prepubertal transgender youth will continue to identify as transgender in adolescence? Raise your hand if you think it's 10%. Raise your hand if you think it's 20%. You guys are too good. That used to be the answer on the boards. We'll talk about why it's not the answer anymore. Who thinks it's 80%? Most people. Who thinks it's 95%? People. So best data suggests it's probably closer to 95%. The idea that 80% of prepubertal trans kids would grow up to be cisgender and gay, this 80% desistent statistic, comes from a handful of papers, but the most famous one was this paper in 2013 from the Dutch group in JCAP. And what they did was they looked at kids who were referred to gender clinics as prepubertal children, and then followed them up later to see if they met criteria for gender identity disorder. The problem here is that a lot of the kids in those studies didn't meet criteria for the gender identity disorder diagnosis. Probably around half actually didn't meet criteria. And there's a problem with that older diagnosis in that it didn't require you to be trans. So if you were a prepubertal boy and birth sign male, and most of your friends were girls and you liked feminine play and dolls and dresses, then you could meet criteria for gender identity disorder. Even though you weren't trans. So Christina Olson at Princeton went back and looked at these studies and found as many as 90% of kids in those studies, when asked their gender identity, reported their sex. So they were probably mostly cisgender kids with gender atypical interests. It wasn't until many years later that we got this great study from Christina Olson at Princeton from the Trans Youth Study. She followed 317 prepubertal trans children who actually asserted a gender identity different from their sex, followed them for 5 years, and 97.5% of them still identify as trans 5 years later. Historically, there have been 3 approaches to treating prepubertal trans youth. I put all 3 of them up here. The first is the living your own skin model. This was popularized by Ken Zucker at University of Toronto at Sick Kids. And this approach said that for prepubertal kids to do psychotherapy to try and push them to identify with their birth sex. It also recommended against a social transition. So if a kid wanted to use a new name or pronouns or clothes, you would tell the parents not to allow them to do that. The logic was that they thought most of these kids were going to desist in their trans identity, so they would argue that they were, quote, hastening the process of desistance. Worth saying that that would generally be considered gender identity conversion efforts, and is currently illegal in half the states, obviously. We'll see how that evolves. On the opposite end of the spectrum is the gender affirmative model. Probably the most famous person to write about this was Diane Aronsaft. She's at UCSF. She recommended that for prepubertal kids, if you tried to force them to identify with their birth sex, you were going to instill shame, cause damage between the parents and the kid, cause damage between the therapist's relationship with the kid. And so don't try and force the kid to identify with their birth sex. And then if the kid wants to explore a social transition, like a new name or pronouns, etc., you would let them do that while paying close attention to the community and environment to make sure the kid's not bullied and harassed. There's an intermediate model called the watchful waiting model. This is popularized by the Dutch. They said to not do conversion therapy, so don't try and force the kid to identify with their birth sex, but to wait until the onset of puberty or adolescence to pursue a social transition. If that was confusing, it's okay, because it really comes down to 2 questions. The first one is prepubertal social transition, good or bad? The second question is conversion therapy, good or bad? And let's talk about social transition first. It's an area where we don't have a ton of data, but I'll tell you the data that we do have. So on this graph, as you go towards the right, those are higher levels of anxiety and depression. Green is the normal range, orange is the preclinical range, red is the clinical range. And I put 3 groups of kids up here. So you can see that first group are kids in the US from Christina Olsen's group who were allowed to socially transition. And at least in the short term, they had very good mental health outcomes. Pretty much normative rates of anxiety and depression, slightly more anxious than their siblings. That's in contrast to 2 groups of kids from Toronto and Amsterdam, prepubertal kids who were told they could not socially transition. Their mean internalizing scores were there in the 3-month range. Imperfect comparison for a million reasons, right? Kids are in different countries, data collected in different years. But at least what we can see is that kids who are allowed to socially transition in supportive environments can do quite well. A question we get a lot is whether or not that early social transition makes it more likely that the kid will continue to identify as trans. So there's this idea that an early social transition might lock in a trans identity, and then the argument against the social transition would be that those kids are going to be locked in and later need hormones and surgery that otherwise maybe they would not need. So Dr. Wilson looked at this also. This is a paper in Psychological Science. And what we knew before this study was that old study that looked at the kids referred to the gender clinics. There was an association between social transition and identifying as trans in adolescence. But that could mean 2 things, right? It could mean that the social transition made them identify more strongly as trans, and so they persisted. Or it could be that the kids who were trans to begin with were the ones who socially transitioned. Does that make sense? So this study looked specifically at that question, measured degree of gender incongruence before and after the social transition, and found that it did not increase. So the social transition didn't intensify the degree of gender incongruence, but rather, if you look at time point 1, the more gender incongruence you have, that predicts if you're going to socially transition. So this seems to argue against that kind of locking in idea. One really important thing to know about social transition is that it doesn't occur in a vacuum, right? It occurs in the child's environment. And so we published this paper in the Journal of Adolescent Health, where we looked at social transition as a prepubertal child, as an adolescent, or waiting until adulthood to socially transition. And we found that those who transitioned early actually had a higher odds of suicidality in adulthood than those who waited until they were adults to socially transition. It turns out we had done a bad job with adjusting for confounders. Does anyone have a guess of why we may have seen higher suicidality in those who transitioned early? Bullying, yeah, okay, you thought of it faster than we did. So we went back and realized that we had a variable for K-12 harassment based on gender identity. And when we included that in the model, that higher odds of suicidality went away. And in fact, early social transition appeared protective, at least for some substance use measures. So that's social transition. The other question for prepubertal kids has been conversion efforts, or attempts to force trans people to identify with their birth sex. We published this paper in JAMA Psychiatry back in 2019. We had a sample of over 27,000 trans adults. We compared those who spoke with a therapist and the therapist did not try and change their gender to those who spoke with a therapist and the therapist tried to force them to identify with their birth sex. We adjusted for a ton of confounders and found that exposure to conversion therapy for gender was associated with a whole range of adverse mental health outcomes, including suicidality. I'll say at the time, nobody was advocating for this after the onset of puberty. So the debates were really about the pubertal kids. So we specifically looked at exposure before age 10. And we found that that actually was more strongly associated with bad outcomes. If you look at lifetime suicide attempts, those who were exposed to conversion efforts as young children had a 4-fold increased odds of attempting suicide. If you think about it, it makes sense, right? That these young kids are in an early developmental period where they're starting to develop a sense of self, self-esteem, and if they're getting early messages that who they are is wrong and that they are later trans adults, that can have adverse mental health effects. So conversion therapy is still legal in most US states, even before that Supreme Court ruling. The states in dark green are states that have banned the practice, although usually only for minors, and usually only for licensed professionals. And the rest of the states, it was legal. Obviously, after the Supreme Court case, those green states might turn yellow. This is a study we published in the American Journal of Public Health, where we looked at how common it was for trans people to be exposed to conversion therapy for their transness. We found 13.5% had been exposed in their lifetime. We were surprised by where it happened, so we kind of expected that there would be more conversion therapy in the American South, but it was mostly in these mountain states. So this is a heat map where dark blue is lower rates of exposure, dark red is higher. Another thing to know is that there are disparities within those exposed to conversion therapy. So ethno-racially minoritized people are more likely to be exposed to conversion therapy than white people. And trans people are more likely to be exposed to conversion therapy than cis people. This is unpublished and under review now, but we did a difference in differences analysis. That's one of those causal inference methods to look at whether or not conversion therapy bans are effective in dropping suicide attempt rates. And we found that they were, with a huge effect size. So we found that conversion therapy bans led to a 6.3 percentage point drop in past year suicide attempt rates. We had to do it with sexual minority youth because we were using YRBSS data where they haven't collected gender identity data in a long time. Okay, next is early adolescence and puberty blockers. One thing that's always missed in the media is that kids don't just come into the doctor's office and then get puberty blockers or hormones. So under current guidelines, both the Endocrine Society guidelines and the WPATH guidelines, you need to undergo a comprehensive mental health assessment if you're going to access these interventions before age 18. So this is a QR code for clinical perspectives we published in JCAT that talks a bit about what goes into those assessments. It's different depending on the unique situation of the kid. But things like gender history, screening for other mental health conditions, being sure about your differential diagnosis, making sure other mental health conditions are reasonably well controlled, but we can go into more detail there. One thing to know about the WPATH guidelines is that they name a few situations in which you would, quote, extend the diagnostic process for considering these medical interventions. One of those is if you realized your gender identity after the onset of puberty, so, quote, late onset gender dysphoria, if you will. So we were curious in how common that is for trans adults, and more common than you would think. So this is a histogram looking at the age at which people share this right graph. Yeah, came to realize their gender identity. 60% did realize as prepubertal children, but 40% didn't realize until after the onset of puberty. So if you see someone, an adolescent, who's coming to realize it after the onset of puberty, just know that that's not necessarily uncommon, and in fact is the experience for a large number of trans adults. Another sad thing from that study is that a median 14 years elapsed between realizing that you were trans and telling another person. And so you'll often hear this idea of rapid onset gender dysphoria, where from the parent's perspective, kids came to identify as trans all of a sudden. And there's been 1 or 2 studies where they interviewed parents about their kids' experience, and the parents said, my kid became trans all of a sudden, but they didn't interview the kids to ask them how long they had known. So if you actually interview trans adults, there's over a decade, generally elapses between realizing and telling someone. So back to the medical intervention. So let's say a young person has reached 10 or 2, has gender dysphoria that's causing significant impairment. That could be things like not being able to shower, not being able to go to school. You might consider a puberty blocker. I'm going to spare you physiology, unless people want to know later. But just know these are reversible medications. It's usually a subcutaneous implant, marketed to last a year, usually last 2 years. They can be removed. And there are depot injections that are every 3 months. The medication will pause puberty, which is helpful for kids whose gender dysphoria is causing impairment, so that they can have more time to decide what to do next. Either stop the puberty blocker and go through their birth, endogenous puberty, or later start gender-affirming hormones, which we'll talk about. But important to know that the pubertal suppression itself is reversible. Our Dutch colleagues were the first to publish on this approach for trans kids. Amsterdam is very pretty, you should go. But they published this landmark case report in 1998 where they talked about a young trans boy, came out as trans. Parents took the kid to a therapist, I believe for years, where the therapist tried to push the kid to identify with their birth sex. It was unsuccessful. And a community endocrinologist actually prescribed a puberty blocker. We'll always give the fancy academics the credit for it, but they didn't give it to the kid. The kid later went to the Center for Expertise for Gender Dysphoria in Amsterdam, got testosterone and a hysterectomy, and had a very good outcome. So since then, there's been more and more interest in this approach for adolescent gender dysphoria. These are the studies we have on pubertal suppression specifically. To this earlier question about level of evidence, there are 2 types of studies. No randomized controlled trials. There are longitudinal cohort studies that have looked before and after puberty blockers and generally found either improvement in mental health after the puberty blocker or a non-worsening of mental health with no control group. Probably the most famous one there is the Carmichael study, which gets cited all the time as saying puberty blockers don't work. A few things to know about that study is a lot of the kids got puberty blockers way too late. So they were mostly through puberty, and it probably wasn't very useful to give them hot flashes. So perhaps not surprising that it didn't work. But also there was no control group. So those kids, their mental health appeared to stabilize, whereas generally what we see with kids who have gender dysphoria where their puberty is progressing is their mental health worsens. So if that study had had a group of kids who didn't get treatment, it would have been more interesting to look at the gap between treatment and no treatment. To that point, we have studies that are cross-sectional studies comparing those who access puberty blockers to those who desired but weren't able to access them. And in those studies, those who access the puberty blockers have better mental health than those who don't. With observational studies like this, you want to think about a lot of things, right? Did they get concurrent therapy? And it was actually the therapy that made them better, not the puberty blocker. So the COSTA study looks at that and finds that those who got puberty blockers do better than those who got just therapy. Others control for things like family support, et cetera, but you have to kind of dig in to see what those differences are, and that's almost always lost when a systematic review is done. Okay, that's puberty blockers. Later in adolescence, you might think about gender-affirming hormones. So the older Endocrine Society guidelines, which are now very old, to 2009, said to wait until age 16, because that's what most of the data were based on. It's also probably an artifact that that's the age of independent medical decision-making in the Netherlands, where a lot of the research is being done. But that's what the guidelines said for a long time. You had to wait until 16 for hormones. over time, there was more clinical experience that young people, especially those who came out as trans early, maybe got a puberty blocker for the first time when they were 10, had the puberty blocker replaced when they were 12, now we're 14 and are looking at their doctors saying, all of my friends are going through puberty and I'm stuck in this prepubertal state. And the doctors looking and seeing that they're falling behind on bone density from their puberty blocker without hormones. When you start hormones, you catch up on bone density. So the latest guidelines recognize that you could start earlier, as early as age 13 and a half, while acknowledging that there's not quite as much data for that, though more data has been published since that was the decision. The WCAP guidelines removed age requirements, which has been controversial. I would say, at least the way I look at that, and I think a lot of providers look at it, is within the context of the Endocrine Society guidelines, that even though there's no strict age cutoff in WCAP, you're not going to start hormones at like age 10, right? It's still generally this like 14 to 16 range, or later, obviously. Similar body of evidence for gender-affirming hormones in adolescents. Some longitudinal cohort studies looking before and after treatment, finding improvement in mental health after. Probably the most famous one lately has been this Chen et al. Study from 2023 in the New England Journal. They followed 315 adolescents and found improvements in appearance congruence, life satisfaction, depression, and anxiety. To get a causal inference, they also did some parallel trend models and found that improvements in mental health were predicted by improvement in body congruence. So suggesting that it is the actual physical changes from the hormones in your body aligning with your gender that's predicting the improvement. And then again, cross-sectional studies comparing those who access treatment to those who desire but did not. Those have generally found those who access treatment have better mental health outcomes than those who do not. This is a newish study on satisfaction and regret following gender-affirming medical care during adolescence. 220 kids, which was impressive. Also a really impressive retention rate. I would say most academic medical centers don't do a good job at this, right? There's large clinic drop-off, people move, or you lose contact. Christina Olson's group is novel in that it's not based in any medical clinic. She's really a developmental psychologist who doesn't do any clinical care. So it's really just focused on keeping these kids in the study and tracking them and following up. So 94% retention rate. The kids were followed a mean 5 years after pubertal suppression, 3.4 years after hormones, and only 4% expressed any regret, where if you're familiar with other medical interventions, that's astoundingly low. But it didn't have details on what exactly the regret was about. And half of those who expressed some regret were continuing on with the treatment, so suggesting that there were downsides or things that they regretted or didn't like, but the positives appear to outweigh that and that they were continuing treatment. Some of the kind of early notes that she had on the reasons for regret were adverse effects or developmental delay compared to peers, which is what we were talking about earlier. That you have to stay on puberty blockers for a while, usually, while your peers are going through puberty, and that can cause social distress. Different type of study. So this didn't look at what percentage of kids take treatment and then stop them or regret them, but was a convenient sample recruiting people online, just trying to find people all around the world who discontinued their medical care. This author is controversial. She's famous for the rapid onset gender dysphoria study, which overstated its conclusions and needed a correction later. But there's some reasons that I do find that this study, I think, is probably not entirely fabricated. And it's that the answers were somewhat nuanced. So again, it doesn't look at how many people are going to regret treatment or stop treatment. Also, the mean age of people starting medication was 22, so most of them were getting treatment in the adult model that didn't have a comprehensive mental health assessment prior to starting interventions. But 29% said that they stopped hormones because of an external factor, so harassment, stigma, etc. Only 30% wished that they hadn't done it. 34% felt it was a necessary part of their journey. 50% said they were both helped and harmed. A third felt they were only harmed. And the cited reasons for detransition included that their gender dysphoria was from trauma or another mental health condition, that it was from internalized misogyny, internalized homophobia, or social influence. on this because these are controversial notions, and they probably sound familiar from kind of the ex-gay movement in the past, right? That a lot of people who went through gay conversion therapy or entered social environments that told them being gay was a mental illness were told that these things were true about themselves and believed them for a long period of time, right? People were told you're gay because you had a sexual trauma as a child. You're gay because of peer pressure. And it wasn't until, probably a decade or decades later that those people later came out and said, I still am gay, and I think I was gaslit into those ideas more than them being true. Nonetheless, we take these seriously, and we try to incorporate them into our assessment protocols to make the risk of regret as low as we can. This was kind of my point. So detransition can be from external factors, right? Harassment, discrimination, kind of forcing you that this isn't worth it, it's too hard, I'm gonna present as cisgender again. But also if you're constantly hearing those messages that being trans is a mental illness, it's from trauma, you might start to internalize that and believe it, whether it's true or not. So really complicated if you have someone stopping hormones. But this is a paper we published. This is a JCAP one, there's one in JAMA Peds also. Just about how you can try and break this down for people. So thinking about external factors, thinking about internal factors, and also how can there be interplay between the two. And you'll see in this JCAP paper that we try to incorporate those ideas. So the way we'll talk to people is say, there's no evidence that trauma, for instance, causes you to be trans. That being said, there are some people who say that their individual experience was that they identified as trans after a trauma, and then later felt that their trans identity was from that trauma, and they actually identified as cisgender again. A lot of things could be happening with those people. We're not sure. They could have been gaslit into those ideas. But I would hate for you to take testosterone and then encounter that idea for the first time years later, and it'd be a really scary thought. Do you have any thoughts on that? We can usually have good discussions around that. Same thing with internalized misogyny, same thing with internalized homophobia. That's it. I was hoping we'd have time for questions. I think we do. This is a shameless plug for my book that has a lot more detail on all of these things. And these are just common questions that people often have or want to talk about. I have appendix slides for some of them. But we can really talk about whatever would be helpful to you all.
So if people have questions, people would come up to the microphone.
Yes. Hello. Thank you so much for the wonderful talk. Daniel Rice from Loma Linda University, Rising PGY3. So I was kind of wondering if you have patients who are coming into your clinic who are interested in transitioning, but your university doesn't necessarily have any kind of major academic center that's going to be able to do this. The nearest one's an hour away, and they may not have access to it. Where would you start as kind of the first steps for helping these people on their journey as they're saying, hey, I'm interested in transitioning, I'm interested in getting some of this care?
Sorry, remind me where you are again.
Loma Linda University, so it's Southern California.
Gotcha.
And are you thinking specifically about youth or adults or both?
Currently I'm a child clinic, so usually under the age of 18, mostly adolescents, but we do get prepubescent as well.
Yeah, so we just specify because there has been a lot of youth care, particularly for people starting on puberty blockers that have been associated with academic centers that provide more comprehensive psychosocial interventions as well as mental health evaluations and medical care, whereas for older folks that's less common in this country. Unfortunately, many of the youth centers have been shut down, and you mentioned Southern California, where most of the children's hospital programs were shut down, although Raby in Orange County and San Diego has opened up again,
in response to court action, and but the access is pretty tenuous in much of the country. I saw one statistic at one point that 40% of the academic centers providing youth care had stopped, and it's probably more now. And so youth are more and more receiving care in the community. Even actually, our presenter who couldn't make it today does direct primary care, where youth can get care without any billing for Medicaid or private insurance, so that if that care is either banned or pressured to end because of government interference, people can still get care. It is a shame, though, because there are some great programs that really had extensive interdisciplinary work that are no longer, and perhaps the majority of them. And so people, families are going where they can to get care.
Yeah, just to make sure people have context. So the pressure on universities and hospital systems and providers is very intense from the Trump administration. So there's the proposed CMS rule that would take all Medicare and Medicaid funding away from any university or hospital that receives Medicare and Medicaid funding. So no hospital can really survive that, right? And so if that goes into effect, I think a lot of us expect that most of the academic medical center clinics will close. Because people realize that that's happening, we are starting to see more community clinics pop up that just don't take any public insurance, they just take commercial insurance. And so, yeah, I think of it as kind of how it was maybe a decade ago, that there weren't very many clinics. We're just kind of getting back to that. You will sometimes find a one-off provider, just like a private practice pediatric endocrinologist or adolescent medicine doctor who will feel comfortable doing it outside of the medical center, but you kind of have to network and find them.
And I'll just add that things are still really in flux. So judges have stopped enforcement of RFK Jr.'s pronouncement that was at the start of this session, where all funding will be taken away. So I testified in a case of one children's hospital where they abruptly stopped care for all of the youth in response to the RFK Jr. threat. And the response from their lawyers, it was, is it better that we stop providing care to trans kids, or if we stop providing care to trans kids and we can't give chemotherapy to the cancer kids? And my thought is that that's not a question we should have to answer in this country in 2026. But it's still really in flux, and the CMS rules are progressing along, and there'll probably be another attempt to shut down really all care, except maybe direct primary care, maybe even private insurance care for youth, youth and adults who are 18 at a minimum. And in some states, care for adults as well, as is already happening. But people are finding ways to get care, and there are contingencies. I know in San Francisco as well as elsewhere for people to receive care in blue states with direct primary care where there's no insurance money involved, and so that they'll still get care, but that leaves out people who lack the resources for that, and so it's not an adequate substitute. Next question.
So at a prior forum, a speaker suggested that if you treat kids before puberty, you run the risk that they'll never develop the capacity for sexual excitement, sexual sensitivity. Can you address that?
Yeah, so there was a Dutch study where they compared trans women who, as youth, had received puberty blockers versus those who had transitioned later, and compared their sexual functioning into cisgender adult females. So they were looking at them all once they were adults, but looking back. And those who had received puberty blockers actually had slightly better sexual functioning than those who had transitioned later. And in all of those groups, it was similar to sexual functioning in cisgender women. So this assertion is simply inaccurate.
There's another Dutch study by Bunchner et al., 2020 in pediatrics, where they looked at sexual functioning before and after these various medical interventions and found improvement after. That being said, sexual functioning is really complicated. So I have plenty of patients who got puberty blockers, hormones, vaginoplasty, and have fine sexual functioning. In fact, sometimes they talk to me more about it than I want them to. But I have other cases where it is a lot harder. And I find setting well, not kids, now young adults, sex therapy can be really helpful because there's so many factors involved, right? There's how comfortable are they with their physical body from their gender dysphoria. A lot of these kids have had trauma. A lot of them are really afraid of how people are going to react when they find out that they're trans. If you're a psychiatrist, the patient's on psychiatric medications, a million of those cause sexual dysfunction. So it's just important to keep a broad differential.
Thank you. Next question.
Hi, so I'm a psychiatrist in Park City, Utah, and about 15% of my patients are transgender adults. And my question is more about like sort of how to integrate effective psychotherapy into follow-up with this population. Because personally, like I find myself feeling like helpless and hopeless, like you were sort of referring to early on, and leaning on sort of just supportive principles, but like CBT sort of feels infantilizing since it's like, yes, there is real danger here. And just kind of curious at your thoughts there.
Yeah, I mean, that was my thoughts when I had the slide of the government's proposal that when you take a trans woman who's had vaginoplasty and in a women's prison, and you cut off her hormones and put her in a men's prison, that then CBT is going to actually be a substitute for her having lived her previous life. But I do think that there are aspects of cognitive behavioral aspects that are helpful, that it is necessary for in this environment of extreme stress where people really don't know what's going to happen tomorrow, for people to be able to get up in the morning and go to work and have their relationships and live their normal lives. And so I think that all of the ways that people do that through better coping skills, through mindfulness, through psychotherapy if they need it, through antidepressants if they need it, that all those things are important, and we as psychiatrists do really have a vital role, and instilling hope is challenging in this environment, and yet we also need to do that as part of our work, and while not being Pollyanna-ish, and that is a difficult balance to strike. I think that if you look at historical comparisons of people and places of increasing threat, maybe the most effective thing is helping people relocate somewhere safer, but it's not a possibility for many of our patients, and so helping them get through the stressors and the uncertainty, is critical.
John Pachinkas also has a great paper on incorporating minority stress principles into other evidence-based practices. So it's called Model for Adapting Evidence-Based Interventions to be LGBTQ Affirmative. But one part is psychoeducation, so I'll often put up that chart describing minority stress and how the internal proximal factors work, and just being able to recognize when that's happening for people is helpful, and then you can do cognitive restructuring around it. So if you have people who are often thinking, no one's ever going to love me because I'm trans,
I'm mentally ill because I'm trans. Candace Owen said that being transgender is like being transracial. These are all real examples. I will kind of like try and elicit those and then sit down and do cognitive restructuring around like what is the evidence for and what is the evidence against. And try and have little mantras so that they don't challenge those in the moment. So I think as much as we try. But those internalized thought processes that really bother people, I think are more amenable.
Next question.
Yeah, I'm a psychiatrist at UT Houston. About 10 years ago, I was approached by a plastic surgeon who wanted to start a transition clinic. Partner in endocrinology, OB-GYN, urology. We had this great program going. And then about February 2025, it magically disappeared from the website, and no mention of it existed in our university ever again. And it seems that in Houston, they've systematically started to break down everything regarding transgender care in medicine. And I'm not sure if you're familiar with the verdict yesterday that came out in Texas. Texas Children's Hospital is now required by law to provide detransitioning services that they have to pay for the next 5 years as part of the settlement. And they also had to fire the 5 doctors that were providing the transgender care.
Right, presumably the doctors who should staff this detransition clinic.
Yeah, and that's what I was going to ask. Is
Right.
how, just thoughts. I mean, now we're going to have this mandatory detransition clinic run by, I have no idea who wants to volunteer for that job.
Yeah, I mean, I'm fascinated. I almost want to volunteer for that job because
If the care is free, where else in this country do you get free care except the detransition clinic is going to be entirely free care?
Well, the
The model maybe for all care in this country.
well, and a ton of kids are being detransitioned, right? Every single kid in Texas, they took away their medical treatment, so they are all being forcibly detransitioned. So,
Yeah.
in a way, I think they think it's people who came to realize they were cisgender, but there are a lot of people who were forcibly detransitioned. I don't know if they'll feel brave enough to go to this clinic that is political.
I wonder if, and besides firing physicians, whether they drop the charges because they dropped the charges on all of those.
That was part of the settlement, why Texas Children settled, is that they dropped all the charges against the physicians and staff that did it.
That's good, because I was going to be an expert in one of those cases. Maybe that's for the best, and those doctors can move out of Texas and take care of people elsewhere. But I agree with you. Who better to work on detransition than people who do have experience with this, whether it's mental health providers or endocrinologists. How many pediatric endocrinologists are left in Texas, at this point? I've known so many who moved to other states, like reproductive health people moving out of affected states. And it'll be interesting to see how many patients they have, how many providers, what kind of care they give, the systematic reviews they're going to use anyway, it's another curiosity of this era. Texas also has a detransition law firm that only does detransition. There's a team of lawyers, although at least one of them now works, I think, in the Department of Justice. But this whole infrastructure for detransitioners, which it's great if they can get all of the, whether it's medical or legal services or whatever they need, but it does seem very artificially, constructed for a very small number of people.
Thank you.
Yes?
My name is Tyler Yorkson. I'm a PGY3. I just wanted to thank you for this presentation. I really loved it, and I had kind of a two-piece question. First, I was wondering if there's any way to get access to the slides to be able to review again in the future, such as
Should we just have people contact us if you can contact us and we'll be happy. I'm certainly happy to send slides and stuff like that as well. I don't know if EPA has any. Oh, you can put them on the app. Yeah. I'm not sure, but you can feel free to, I think both of us are easily found with Google, and if anyone's interested, you can feel free to contact us for slides.
And then my second question was, you mentioned transition, and then feelings of regret versus non-regret. I was wondering if there's ever been any studies seeing if there's any correlation about what period of time in life someone is in where those might show up. I'm thinking about where someone is taking certain period of time where it's more common versus less common.
Trying to think of any of the study. So your first point is an important one, that there are a bunch of different studies that operationalize detransition differently. So some of them are just having started hormones, some of them are actually regretting treatment. The studies that are conducted, like my Christine Olsen study, look out 5 years. So people are still relatively young. I don't know that I know of one that looks at trying to break down. Almost so small and qualitative. I don't think there's a great statistic that would break it down in a convincing way.
I mean, in my clinical experience, certainly with that, if we're then extending it, because there's been so much focus on youth, but in terms of adults, that there have been adults who detransitioned either because of circumstance.
That was the session 1193 from the American Psychiatric Association's annual meeting in San Francisco. Tomorrow, we will release session 2. Work like this takes significant resources. Journalism takes time, verification takes time, production takes time, and the professionals who make this possible need some kind of compensation. We provide this content without a paywall because we believe it belongs to everyone who needs it, to the patients, to their parents, to clinicians, and to people making decisions that will shape the lives of children for generations. If you believe that too, and you are in a position to support it, please consider becoming a paid subscriber to Inform Dissent or to the LGB Courage Coalition Substack. Your support makes it possible for those who cannot pay to still hear what they need to hear. You can also follow our work and contribute at lgbcourage.org. We'll see you tomorrow. And as always, stay informed and ready to dissent.